So, in the medical management of obesity, this is the problem that we face, ladies and gentlemen. The problem is that obesity runs in our family. Unfortunately, no. The problem is that no one runs in your family. That is a major issue. Obesity is one of the biggest threats among NCDs in India. And if you look at the prevalence of these, 46% is obesity, 33% hypertension, and 26% type 2 diabetes. This is among the non communicable diseases. And unfortunately, obesity has already reached alarming proportions in many parts of our country. Look at this. In 2005 and 2006, we had three states which had a 15% overweight or obese population. In 2015-16, exactly 10 years later, ladies and gentlemen, 19 states had more than 15% overweight obese patients. That's a huge number in just 10 years. And you will be shocked to know that 3 out of 4 Indians are overweight. Yes, 3 out of 4 Indians are overweight. And obesity amongst Indian children is on the rise. Between 1990 and 2014, the number of overweight children in the low and middle income countries doubled from 7.5 to 15.5. And in 2014, 48% of obese children live in Asia. Can you imagine? And Indians between 5 and 19 are increasingly getting obesity, primarily because of a westernization of our diet. And according to a report which was formed by the WHO, it has alarming consequences of blood pressure, type 2 diabetes, heart disease, osteoporosis, and various other factors which you know about. So these are some of the morbid conditions which are related to obesity. You can get atherosclerosis, diabetes, polycystic ovarian disease, hirsutism, hypertension, ischemic heart disease, osteoarthritis, obstructive sleep apnea, restrictive lung disease, and also cancer, especially endometrial, colonic, prostate, and breast cancer. So you can understand that if you treat obesity, you would be getting rid of a lot of these problems. However, you must understand that weight loss will improve obesity related complications only. If you want prevention of type 2 diabetes, then up to 10% weight loss is necessary. For remission of type 2 diabetes, up to 15% weight loss. For dyslipidemia, up to 15% weight loss. Hypertension, 5 to 15%. Non-alcoholic fatty liver, 5 to 15%. For obstructive sleep apnea, 10%. And for all the others, such as stress incontinence, psoriasis, gastroesophageal reflux, polycystic ovaries, asthma, etc., you need between 5 to 10% of weight reduction. You must understand why we start at 5%. It is because up to 5% weight loss can even occur with placebo. And that is what is extremely important for you to understand. What are the treatment options that we have for treatment of obesity? Diet and exercise, surgery, and medical. My job, ladies and gentlemen, is to talk to you about the medical aspects of treatment options. Basically, there are three mechanisms of action, three mechanisms for obesity medication. One is to decrease the food intake by reducing appetite or increasing satiety. The second is to decrease the absorption from the gut. And the third is an increase in energy expenditure. Unfortunately, the last, that is an increase in energy expenditure, nowhere in the world, especially in the United States, has this been approved. No drug has been approved. For example, ephedrine, norepinephrine, etc. These are drugs which are used to increase energy expenditure. But under the law, you cannot use it. Unfortunately, and I say it very seriously, unfortunately, A lot of gyms, a lot of gym trainers are using this drug in mixed stress, especially one which is called Rip Fuel. And you will be shocked to know that I have lost a nephew of mine who inadvertently took Rip Fuel. Now, in the anti-obesity drugs, you have these Zenical, which is orlistat, Belvic, which is locazarine, Contrar, which is bupropion naltrexone combination, Kismia, which is a phentermine topiramate combination, Saxenda, which is liraglutide, dulaglutide, Trulicity, and of course, semaglutide. And I shall discuss some of these with you a little bit in detail. So looking at the pharmacological options for weight management, if you look at it on the left, you have orlistat, which you can see has been approved both in the European Union and in the United States. It acts by energy wastage. Phentermine is not approved in the European Union, as is phentermine and topiramate. That is also not approved in the European Union. Both of them act by appetite reduction. Naltrexone and bupropion, liraglutide, which is Saxenda, has been approved both in the European Union and the United States. But please remember, all of these are an adjunct to diet and physical activity for chronic weight management. Now, if as you can see on the right, phentermine topiramate act at the, sorry, at the GABA receptors and also at the noradrenergic and the dopaminergic receptors, while liraglutide acts in the gut and in the thalamus at the GLP-1 receptor. Naltrexone, bupropion, phentermine all act at the dopaminergic receptors, and orlistat acts on, of course, the pancreatic lipase. So if you look at noradrenergic agents, phentermine has been approved for weight loss less than 12 weeks. Fortunately, monotherapy has not been associated with valvular disease. But when phentermine was combined with fenfluramine, what was known as fenflur, at that time you had valvular disease occurring in the heart. But phentermine on its own does not cause anything, and that is why it has got approval. Phenylpropylamine has been approved as an over-the-counter appetite suppressant, but was withdrawn due to the risk of hemorrhagic stroke. So amongst the non-adrenergic agents, you only have phentermine which is available. Then you have the drugs which suppress appetite. And amongst the appetite suppressing medications are lorcaserin, which is a selective serotonin 2C receptor agonist. It increases weight loss from 2.2 to 5.8 kilograms compared with placebo. Unfortunately, as is the case with most of these medications, the weight returns to baseline after medication was stopped. It's been approved by the United States Food and Drugs Authority since July 2012. And you can see from here the lorcaserin effectiveness. It's very beautiful, and you can see that if you use it beyond 1 year also, that the effect continues. And what is beautifully seen here is this one. You can see that when you use it for 1 year, the weight loss is there. The moment you stop using it, you start gaining weight again. Then you have medications that reduce absorption. That is orlistat, which is available abroad as Zenical. It binds the gastrointestinal lipases, preventing hydrolysis of dietary fats. So what happens is about 1/3 of fat calories is excreted in the stools, and patients lose about 9% of body weight. As I told you, 5% body weight loss is always and can always be attributed to placebo. This weight loss, which orlistat gives, is associated with a decreased blood pressure and a decrease in fasting insulin levels. So it's extremely effective for patients who have a high insulin level or who are insulin resistant. Because it causes the fat to be lost, you should always take fat soluble vitamins as daily vitamin supplements. Unfortunately, again, I repeat, once the medication is stopped, weight is regained. And you can see from here, this is a normal function. And this is what happens when you give orlistat. The gastrointestinal lipase is blocked over here in the lower frame, and triglycerides, etc., are all excreted in the stool. Then you have phentermine topiramate combination, also called Kismia, which is approved by the US FDA in July 2012. Phentermine reduces appetite and decreases oral intake, while topiramate is an appetite suppressant and a satiety enhancer, acting at the hypothalamus. It's given daily in the morning because it causes insomnia. And believe me, it causes insomnia. If you take it at night, you probably won't sleep the whole night. You normally start in a dose of 3.75, 23 for 40 days, and then you increase it to 7.5, 46, etc., up to 12 weeks. At 12 weeks, if you find that you have less than 3% weight loss, you have the choice of stopping it or going up further, provided that the insomnia is not too bad, if headache is not too bad, if nausea is not too bad, you can increase the dose even to 11.25 to 69. Again, after 12 weeks, you recheck. If there is less than 5% body weight loss, you should stop Kismia. However, if there's more, you can continue it. And this is exactly what is shown in this slide. You can see what happens as the dose increases and the body weight continues. This is up to 56 weight, going right up to the end. And you can see the degree of weight loss when compared to placebo. Placebo is the blue one, and the pink one is 7.5, and the green one is 15 milligrams of phentermine, suggesting that with an increase in dose, you have greater weight loss. There is a significant improvement with treatment. And not only does your weight go down, but so does your blood pressure, your lipid concentration, and your blood glucose levels. So it's a win-win situation. But unfortunately, there are certain risks, such as nephrolithiasis, hypokalemia, dry mouth, paresthesia, constipation, and insomnia. And that is why in these patients, you need to keep extremely hydrated, right? These are some of the common side effects. Nephrolithiasis is something which people are really worried about when you take Kismia. Then you have the combination of bupropion and naltrexone, which is Contrav. It's a combination medicine that was approved in 2014. It was initially rejected because of cardiac problems in 2011, but later approved for adults with BMI of more than 30. It has to be given in conjunction with the weight loss program. In fact, I would not hesitate to say that all the drugs should be given in conjunction with the weight loss program. You should reevaluate at 12 weeks, and it should be stopped if you have not got more than a 5% weight loss. Normally, the patients lose 4% more of body weight with medicine compared to placebo. So you're at about 9% total body weight loss. Nausea is seen in almost more than 30% of patients. More than 1/3 of them complain of nausea. And you do get depression and a suicidal risk. It sometimes causes a rise in the blood pressure. You then have what is a GLP-1 analog, liraglutide, better known as Victoza, which you use for diabetes, where we step up the doses from 0.6 milligram to 1.2 to 1.8 in treatment of diabetes. This is a once a day injectable. However, when you use it, and it's licensed in the USA for weight loss, Saxenda is the name, and patients lose 8% of body weight compared to 2.6% with placebo. I would like to emphasize here that Saxenda is not approved, or liraglutide is not approved in the Indian subcontinent for weight loss. So 3 out of 5 patients using Saxenda lost more than 5% body weight, and 1 out of 3, that's 33%, lost 10% of their body weight, which is really something which is remarkable. And here you can see beautifully the mean change in the body weight versus time. And you can see with the different doses what happens and the degree of weight loss. The maximum being here with Saxenda, which is 3 milligrams of liraglutide. And again, another thing to show you a loss from 233 pounds to 208 pounds, a 25% pound weight loss over a period of 64 weeks, which is substantial. And it actually doesn't give much of side effect. The initial run-in period, you do get a little nausea, but if you build up the dose gradually of Saxenda, then there is no problem. Then you have the other GLP-1 analog, dulaglutide, which is Trulicity. It's again an injectable GLP-1 analog. It's a once a week injection compared to Victoza or Saxenda, which is daily. You get up to 7 to 8% weight loss. However, there are some super responders who even have had 20% body weight loss. However, I would like to emphasize here that liraglutide in almost all trials has proved superior to dulaglutide in reduction of weight. I would again like to emphasize here that even dulaglutide is not sold in India for reduction of body weight. It's not licensed for that. Neither dulaglutide nor liraglutide. So when you look at the pharmacological options for weight management, and you can see the status and the mode of action, which I have already described to you, you can see that the dosing for orlistat is 3 times a day. For phentermine topiramate, it's once a day. For naltrexone, bupropion, it's twice daily. And for the injection, it is a daily injection. All of them are as an adjunct to diet for obesity, including weight loss and maintenance. And if you look at if you look at it, the weight loss which you can expect, 2.9% with orlistat, 8.6% with phentermine, 4.8% with naltrexone, 5.4% with liraglutide. And over the longer term, if you look at it, it's 2.8 with orlistat and 4.2 with liraglutide. If you look at the percentage of patients who achieve more than 10%, 26% achieve that in orlistat, 47% achieve it with phentermine topiramate, and 25% with naltrexone, and 33% with liraglutide. If you want 5% reduction, then almost all of them, look at that. Orlistat gives you 54%, phentermine gives you 67%, naltrexone, bupropion 48%, and liraglutide 63%. And you get good maintenance of weight loss as compared to the treatment before. We then come to the newest kid on the block, the latest human GLP-1 analog, which is semaglutide. And semaglutide, lot of studies have been done, step 1, step 2, step 3, step 4, etc. I would like to tell you that what I'm saying here is that semaglutide in any form is not yet marketed or available in India. Please understand that. It will be available very shortly, but as of today, it is not expected, and I have been strictly asked by Novo to emphasize that to you before using these slides. So if you look at the pharmacotherapy, you have, look at that, placebo 2.4% and 16.9% body weight change with oral semaglutide. February 2021, New England Journal of Medicine. This is a fantastic drug for weight reduction. With 2.4 milligrams, 86.4, 69.1, 50.5, and 32% had weight losses. 32% having a weight loss of more than 20. And if you increase the dose, it just keeps on going on. And it's unbelievable. I mean, you have to see what this drug can sometimes do. So these are the summaries for the step trials, 1, 3, 4, and step 2. And you can see everywhere that the weight loss is substantial. However, I'd like to emphasize again, please read on right on top on the right, semaglutide in any form is not marketed or available in India. Now, if you look at off-label use, you can use metformin, you can use the pramlintide, and you can use the SGLT2 inhibitor, just empagliflozin, dapagliflozin, and canagliflozin. And you know, a very good combination for weight loss in a diabetic patient would be metformin, a GLP-1 analog, and of course an SGLT2 inhibitor. Just as an aside before I finish, you must understand that a human chorionic gonadotropin was first suggested as treatment for obesity in 1954 in a Lancet paper. It became popular in 1970s, and the current popularity is because of Dr. Kevin Trudeau's 2007 book, which said that the weight loss cure that they don't want you to know you about, and the miracle weight loss breakthrough. Very fortunately, the Federal Trade Commission ordered Mr. Trudeau to pay $37 million as damages for false claims with HCG. So, ladies and gentlemen, with obesity reduction, you can have an improved quality of life, a decrease in sleep apnea, an improvement in fertility, a decrease in gout, a reduction of blood pressure and diabetes, perhaps less cancers occurring, perhaps less coronary artery disease, and perhaps less gallstones. So I think that we should definitely try and control obesity. Thank you